You're having cognitive symptoms. Do I need an MRI? That's the question that people ask me all the time. So let's talk about it. What can we learn from imaging? What are the different types of imaging studies? And what are we going to do with the information we get with it? So I'm Dr. Ashanti Gachafira. I'm a board certified neurologist. I have seen probably tens of thousands of MRI scans in my career, and I'd love to talk to you about some of the things that I do every day in looking at people's imaging studies. So you went to your doctor because you said, I have brain fog, maybe it's menopause, maybe I have a brain tumor, my cousin had a brain tumor. These are the things that I hear all the time, and I get it because our brains are super mysterious, and when we feel like they're not working, we want a picture. We want a picture to tell us what's there. And sometimes that's totally appropriate to do. So what are the different types of pictures you can get, and what are they telling us? So let's just break it down, right? A picture that we get from an imaging study is just a static image of our brain tissue. And it can be of various quality, and it can tell us different things, like, is there trauma? Is there blood? Is there inflammation? Is there a skull fracture? Are there tumors? Does it look like there's a stroke? We can tell all of these things depending on the different type of picture we get. Now, different types of images give us a different way of looking at each of those things. And some types of images are better than others for different indications. So to start with, let's go with the most basic that we've been able to do now for over 50 years with it, which is a CAT scan or a CT scan. So CT, or computerized tomography scans, use X-rays to look at a brain in a very comprehensive way. So it's way more than an X-ray, like a single flat X-ray. It looks at a brain in a much more 3D kind of look, but it takes it in slices. And when you look at each slice, you're then able to look at the brain beautifully. Now, a CT is really good at two things, and it's looking at trauma, like blood and fractures, and it's really good at looking at things like stroke, because that's oftentimes a loss of blood flow or a hemorrhage or a bleed, and so we're able to look at those things on a CT scan. The other reason CTs are great is because they can be quick. You don't have to lay down on a scanner for a long time, which is really important if the patient is in the middle of a trauma or a stroke. And also really important if the person is agitated and it's hard to get them to lie down for a long time, or it's uncomfortable, or they're very large, then a CT scan is definitely the way to go. The problem with the CT is it doesn't give us a nice detailed look at the tissue. And for that, we need an MRI, or a magnetic resonance imaging study. And an MRI does not use X-rays. It uses radio waves and a magnet, and it puts these radio waves through the tissue, and then the magnetic force, which is humongous, this humongous magnet, flips the protons in the tissue and then emits a signal, which is then picked up and converted into the image. It's super high-tech technology, but it's been around since the 1990s, and every year a new version of it comes out. It's like, I don't know, like a new iPhone kind of thing, but even more amazing. And every year new technologies and new ways of spinning those protons comes around and giving us even better and better pictures. So MRIs are amazing, and what they can show is the difference between gray matter, between white matter. They can show edema or swelling. They can show inflammation. They can show blood. They can show stroke, not just stroke. They can tell us if a stroke is 1 day old, 2 days old, a week old, 3 weeks old, 3 months old. I mean, it's not super precision, but you can get a very good idea of whether it's an acute event, meaning recent, or whether it's an old event that occurred a long time ago. It can show scar tissue. And then if you add contrast, which is looking at how the blood is taken up in the brain, or how the contrast is taken up through the blood in the brain, then you can really look at even more detailed, so you can see things like active inflammation, or you can look at things like an active, like where the blood vessels are and how they are showing some breakdown of the blood-brain barrier, so you can tell if there's been some inflammation or some damage in the brain. The other thing that's really useful in an MRI is it can look at brain volume in a really specific way. So you can see things like how much shrinkage has there been in the different parts of the brain. And this is really useful when we're talking about something like dementia, because we know there are multiple different types of dementia, but they affect different parts of the brain in different ways. So for very basic example, an Alzheimer's type dementia will have shrinkage in the hippocampus and in the temporal and parietal lobes. In a frontotemporal dementia, just as the name suggests, the shrinkage will be in the frontal and temporal lobes. In a vascular dementia, you may not see specific areas of shrinkage, but you will see an evidence of prior strokes, sometimes, oftentimes, subclinical, meaning the patient didn't even know they had them, but you'll see a lot of what we call microvascular changes or white matter changes, in which there looks like there's been a lot of scar tissue from prior events where there's been a lack of blood flow. And this is very indicative then of vascular dementia. So putting the information together and with a patient's clinical picture and their imaging, we're able to say to some extent whether there is a profile that is consistent with dementia. But here's the thing, our brains are so amazing in their adaptability, in their neuroplasticity, that by the time we see structural changes on brain imaging, the process of something like dementia has been going on for a very long time. So for most people with mild cognitive impairment, mild memory loss, or even mild early stages of dementia, brain imaging will often be normal. I just want to say that again, brain imaging can be normal even in mild stages, early stages of dementia. And this is important because many times patients will come to me and say, I got brain imaging and I was told it looked okay and there was no dementia. And that's just not something we can say based on an MRI scan. Even the highest quality MRI scan can't tell us that. What we do have is a study called a PET scan, or positron emission tomography. And this is a very advanced study that looks at the way a certain molecule is taken up in the brain. And we can now do PET scans that look at glucose. We can do PET scans that look at things like amyloid. We can do, even experimentally, PET scans that look at different types of hormones or different types of proteins. But these are very expensive. They often range $10,000 or more, or are just research-based. And while they can be very helpful, we also know that they have their limits in their availability to people. But what a PET scan can do is it can help differentiate between different types of dementia. So a PET scan can have a very characteristic look in patients with frontotemporal dementia, different from patients with Alzheimer's dementia, and that can be very useful diagnostically. Fortunately, we do also now have serum biomarkers, and I'll try to do a video on that too, serum biomarkers that are very sensitive and specific for looking at things like Alzheimer's dementia compared to a PET scan. So we can spend $250 to $300 versus $10,000 and get pretty much the same information in terms of a diagnostic value. Now, what does this mean? And I just said an MRI doesn't give us the full answer about dementia. Well, why do I check MRIs when I'm looking at dementia prevention? Well, the reason is because if you're extra careful, you look at things with a really critical eye, and you use specific software that looks at the volume of certain areas in the brain, you can then do very good prediction modeling of whether a patient might develop dementia in the future. Specifically for Alzheimer's dementia, we look at hippocampal volume. And I use a particular software called NeuroQuant, no stock in the company. They just run a very well-established software program that works with an MRI scanner and looks very closely at the volume of different regions of the brain, specifically things like the hippocampus, the entorhinal cortex, the prefrontal cortex. They look at these different areas in the brain and they compare those areas, the number of pixels, for example, in a region, or they're actually called voxels, but the number of units of size that they see in these different areas, and they compare them to other people of the same age and same sex. And when they do that, they're then able to give you a percentile volume ranking. So for example, you could be in the 95th percentile, which means you have a larger hippocampus compared to 95% of people. Or you have a 5th percentile hippocampal volume, which means your hippocampus is smaller than 95% of people of your age and sex. And this is helpful because it is a bit of a more functional study. It tells us how big is your hippocampus at this time in your life compared to others of your age. It does not mean you have dementia just because you have a small hippocampus, but it does mean you have less structural resilience to play the long game, as I like to say. Whereas if you have a large hippocampus, then even if you have other high risks, you're starting from a more robust resilience in terms of your structural volume. So there you have it, guys. CT scans, MRIs, PET scans, NeuroQuant. At the end of the day, this is still a clinical diagnosis. Dementia is still a clinical diagnosis. And most importantly, something like dementia prevention is extremely nuanced. Everybody's dementia risks are different, and a brain picture gives us a static image at this time of what your brain looks like. And while it's a useful diagnostic test, it needs to be used in context of everything else that's going on. And when I use it, especially in a dementia prevention model, I look at cognitive testing, I look at blood work, serum biomarkers, whole body health, because our brain is downstream to everything else we're doing. That's right, everything else we're doing, how we eat, how we sleep, how we think, how we apply stimulus to our minds, all of that affects our brains, but our brains may only show the changes downstream decades later. If you're interested in working with me to find out more about dementia prevention, I welcome you to look at my website, healthspanneuro.com. I see patients on a 1 year cognitive longevity program. It is truly the best work of my life, and I also see patients for menopausal brain fog, because menopause is the window of opportunity to take care of your female, powerful, potential brain. And again, I'm Dr. Ashanti Gajavira. I'm a neurologist. I'm at HealthSpan Neurology. I am a doctor, but I am not your doctor. So please seek your doctor for any advice and do not make any medical decisions based on this information. I'll see you next time.